So today we're meeting up with our team at Desert Vision Center to have a discussion about glaucoma. All the technical aspects of it, the subcategories, the treatment. I thought I'd upload this to YouTube. It is a long video, and actually the camera did run out of batteries halfway through, so we're gonna splice it together for you. And if you want to know some more details about glaucoma in lecture format, then this is the video, and I'll start it from here. So, welcome everyone. Hi Francis, you came too. I normally don't record these, but today we are, and the idea is to upload it so that way in case in the future you want to reference it, or let's say we have another team member who can't be here today, they can always access it later online. But today's topic is glaucoma, and we're going to talk broad overview, maybe in a way to get an idea about what it is, what are symptoms, how do we treat it, how do we do the workups. And it's meant to be kind of at the level of a technologist. So, if you don't have any science background or no medical background, and it's maybe a word you don't understand, just feel free, ask anytime. And if there's any questions as we go along, ask anytime. With the camera here, to me it feels a lot more formal, which I don't want it to be that way. I want it to be more of an open discussion. So we have anyone here, question, raise hand, or just ask and we'll stop. So that's always, I think one of you asked this week, what is glaucoma? What really is it? And that's the first question. Because people hear that word, there's like an emotion that comes by. What does it really mean to use eye drops? There's like a common sense of what it is. But by the book terminology of this, let's grab our pen here. By the book definition, glaucoma is an optic neuropathy. So let's write that down. That means it's a disease that affects the optic nerve. So there's optic nerve damage. And the optic neuropathy is progressive. And it is characterized by pretty consistent visual field loss. Here. Let's just put visual field loss because we'll go over that later. And it's usually, but not always, associated with only one modifiable risk factor that we have here, which is eye pressure. So you really kind of have to have these three main points to diagnose glaucoma. You have to have a characteristic visual field, you have to have something that's chronic and progressive, and you have to have some modifiable treatment for the eye pressure. So either the eye pressure is too high, or the optic nerve is too sensitive to whatever pressure there is, and there's axonal injury to the nerves themselves. And that's where the pathophysiology of this is. So, questions on that so far? I mean, that is something you almost have to memorize because it explains a lot why we do our workup. It explains a lot why we don't really usually diagnose glaucoma on just one visit. It takes a series of visits through time, a series of tests through time to really show the progression. And you do have to get a formal visual field, which everyone hates taking that visual field test, but that's part of the criteria. You have to have that test performed. And then there's eye pressure. You always have to measure the eye pressure. So if you memorize that definition, that is probably the most important take home today. What is glaucoma? That's what it is. So we're going to talk about maybe some natural anatomy of this. So if you have a conception of the anatomy, then it will understand what are the subtypes, what are the categories, what are the treatment. Let's go over anatomy. That's pretty important. So we're going to kind of zoom in. If we take maybe a side view of the eye here. I always like to draw this like the same way every time. And if you remember back here, this is the cornea. This is our lens. That's where people get their cataracts. Here's the retina.
Sorry.
And then here is the optic nerve. The damage is back here. So the damage with glaucoma affects the nerve. So we always want to look at the nerve at every examination. That is critical. We're looking at that. Where does the eye pressure come from? Well, let's go over that. Right in the corner here, this is the ciliary body. The ciliary body produces the aqueous. And then the aqueous is going to go around the zonules, around the pupil in this kind of direction. And it fills the front of the eye, or the anterior chamber, which is that space between the cornea and the iris. And as it circulates through there, then it heads out and drains in that tiny little canal there known as Schlemm's Canal. This is kind of a funny name, Schlemm's Canal. So, understanding this anatomy knows, well, we kind of know where aqueous comes from. We know where it drains. That helps us explain some of the treatment already. You can already know if you know some physiology and if you know some of the anatomy, you know how to treat this. We have a faucet inflow, we have a drain outflow. So if we can modulate either the inflow, the outflow, we can bypass that. There are different ways that we can do management. So understanding anatomy really helps here. Questions on any of that so far? Okay. So let me see here. Let's kind of do maybe a more detailed cross-section. So if we take kind of a zoom in on this section, I'm going to draw a couple more features here that you should be aware of. So let's try my my sketch work here. So if we look at the iris, is here, there's the pupil, then we have the insertion of the iris, and then the ciliary body is here. The lens is suspended on zonules. This is the ciliary body, and this is what creates the pressure, or the aqueous. And it's going to travel around the pupil, around the iris, over to here, and there's a little layer of pigmented cells here called the trabecular meshwork. They literally act as a filter into Schlemm's Canal, which actually spans 180 degrees around, and then the other 180, so it actually spans the entire rim of the eye. So if we look on front view, your eye will look kind of like this. Schlemm's Canal goes all the way, it encircles the whole thing. So side view, we're watching that as it goes right into that little canal, and that canal is very tiny. It's, and the lumen diameter might be only 300 microns, let's say. So really tiny. So I'm going to go ahead and erase this because I need more space. Questions on the anatomy, because you really have to understand those main points. Schlemm's Canal, ciliary body, where the aqueous comes from. Okay, let's try that.
Can I do a question?
Yes.
With the iridotomy, is it just making another hole for it to pass through, or is it opening one that already exists?
Great question, and I didn't pay you to do that. That is the next part, which is how do we classify glaucoma? There's so many different ways to classify it. There's genetic ways, there's etiology. What you're talking about is the anatomic way to classify glaucoma. And there truly is, from an anatomic point of view, two main categories, which you've probably heard of. You've heard of open angle, and you've heard of closed angle, or narrow, right? Two main ways. So to understand the laser, we should really talk about the anatomy on these two, and that'll help maybe explain what the laser does and why do we do it. So this we would consider open angle because there's plenty of space between the iris and the cornea. So I would consider that open angle. The angle is literally the angle from the cornea and the iris. So this angle right here that I drew here might be, 40 degrees. So as time goes on, the lens that we're born with grows from an anterior to posterior dimension, and then that's what we call narrow angle. So instead of that configuration, it's going to look like this. So the iris starts to bow forward. It's a larger lens, or it's a shorter eye. Those are the two main reasons. So if this goes forward, now all of a sudden our angle from the cornea to the iris might only be 15 degrees. So now you can see the problem when the ciliary body creates the aqueous. It's trying to get around that, but it's a tight squeeze. It's like when it rains here in the desert, and there's only so much space for the water to go through, then all the roads flood. There's floods everywhere, the wash is there. Well, in the eye, it's not an open structure. It's not like the water can just fill up the next road. It's contained. So when there's excess pressure or aqueous being produced, it has nowhere to go except through the canal. So it builds up, and in that confined space, it's going to make the pressure rise. So instead of waiting for the pressure to go all the way around that whole system, all the way around there, we do a laser. We create an opening in the iris. That's the iridotomy. And now we have a direct path from the ciliary body, that little spot here where the aqueous is produced, and goes right into, it's supposedly, right into Schlemm's canal. So even if your cataract grows a little bigger, and even if this gets more narrow, the aqueous still has another way to get to Schlemm's canal. So that's a really important part to know about glaucoma. If someone tells you they have glaucoma, you kind of have to know whether it's open or closed. If it's narrow, or which is mean partially closed, they have to have an iridotomy before you can dilate. Imagine you have a narrow angle, you don't have an iridotomy yet, and you dilate, the iris will bunch up in the corners, and it's going to potentially clog up that space. Now you're going to push someone into a glaucoma attack. So from a technology workup point of view, how do you tell? Most people don't know the difference. I mean, this is pretty detailed now, so most people don't know. The only way to know is to really visualize it. And the easiest way is, as you're working up a patient, you can shine a flashlight from the side, like over here. Let's say I shine a flashlight here. So imagine they have an iris that's flat. When I shine the flashlight over here, the light's going to travel all the way across. You're going to see no shadow on this side. But let's say the iris is bowed forward. When I shine the light from a side, we're going to get a shadow effect over here. So that's for a really quick, easy, just get a pen light. You can kind of tell, are they narrow or not? If you see anything like that, there's other ways to verify with a slit lamp examination. A lot of techs are quite familiar with slit lamp. There's a test you do right at the slit lamp called Van Herrick. And that's where we take the slit lamp, we aim it from an angle, and we're kind of looking at the shadow. We're trying to assess the space between the iris and the cornea as a ratio of how thick the cornea is and how deep the anterior chamber is. So the Van Herrick method, you can look that method up. That's what I do every single examination because I'm already there at the slit lamp anyway. But if you see something like this on your workup, do this. I'm sure you'll find ways, maybe examples online. If not, let me know. We'll try to get a video of that. If you as a tech see this and then do Van Herrick and say, oh my goodness, it does look a little suspicious for narrow, then let me know. Don't dilate, let me know, and then we confirm with gonioscopy. So interesting fact, if you know about physics, you cannot directly look at Schlemm's canal just by shining a light there, because the curvature of the cornea is such that if I start angling my examination light here, there's a law of internal reflectivity in physics where the light will just start to reflect in and out of the cornea, and it prevents us from looking directly at that spot. So the only way to see that spot is to use a specialized mirror or a specialized lens that has direct contact onto the cornea, and that's called gonioscopy, and that's done in the examination chair with the doctor. And that's how we directly confirm the angle and the health of Schlemm's canal or the trabecular meshwork that's on top of it. Gonioscopy is key to look at this part of the eye, the angle structures of the eye. So for our glaucoma patients, we'll do gonioscopy at least once, especially if there's a concern about narrow angle. So when you think about your testing workup, has gonioscopy been done or not? Are they still phakic or not? Have they had cataract surgery? If they had cataract surgery, now remember we talked about this before, the cataract might be 4 millimeters, but your implant's only 1. So it's extremely rare after cataract to have angle closure or narrow angle, because you've now opened up that space by getting rid of a thick lens that we're born with, putting a little tiny skinny 1 millimeter one in. So from 4 to 1, that opens up potentially some good space in that chamber. Excellent question about the laser. I hope that makes sense. You have to look to make sure this classification tells you, do I need to do the laser or not? And how does it work? We're creating bypass. Now, close angle or narrow angle is a lot less common than the open. Most of your patients that we see are open angle. Close angle is more common in these scenarios. It's going to be in a hyperopic patient. You will sometimes see people who might be emetropic or plano. They're not wearing glasses, but they had LASIK. You have to kind of be worried about those scenarios. But you might have a +3 or a +5 hyperope, and they're more likely to have a shorter eye, crowded structures, and narrow angle. Classically, you'll see someone in their 50s or 60s with that issue. And those are the ones more commonly we're doing the laser iridotomy for. Like a hyperopic 55-year-old comes in and we're doing a routine exam and we screen for that. The other common group that this is like maybe a 20-fold higher risk of angle closure would be like the Inuits or the Eskimos. There's like a family line that has really high risk for narrow angle, and we have a few patients that are from Alaska out here. They fly down for part of their season. And I'm always looking for narrow angle in our Alaskan patients. But anyway, that's a couple risks or a couple things you should know for the narrow angle patient. Now, some people have what are called mixed mechanism. They don't really They might have had closed or narrow angle at some point. We might have already done an iridotomy, but they also, on top of that, have open angle. So I would call this like a mixed mechanism picture. You look in their history, they had an iridotomy when they were 60, and now they're 75, and we're treating them with glaucoma because they have both. They've got both the narrow angle and the open. So even though we have these categories that helps explain and categorize it, it doesn't always fit for every situation. And that's why it's hard with glaucoma. There's multiple ways to classify these. Questions on that so far?
Yeah, what would be the treatment for these mixed mechanism cases?
Well, mixed mechanism, you're already going to have to do an iridotomy. That is a given. If the angle is narrow, you have to do a laser. And in the mixed mechanism, they might have maybe a little bit more of a sensitive nerve. So maybe their axons on the nerve are less resistant to eye pressure, and they can handle it. And even if the pressure is 18, we still have to get the pressure lower. Or let's say we did an iridotomy, but their pressure is still 28. So these are the two situations, and this goes back to the original definition. These two situations are the mixed mechanism. We did an iridotomy, but yeah, we still have to give them the eye drops or do some sort of eye pressure lowering treatment. You want to grab a chair? All right.
I have
Yeah.
the sensitivity of the axons, is that a neurological defect or is it?
That's a great question. There's a lot of research being done on this right now. John Berdahl out of, I think he's in Utah now, I always forget where he is, but he's doing research on the nerve injury here. We can only modify what's in the front, in the pressure of the eye. But what about the pressure of the CSF? What about the pressure of the orbital tissue? So there's other parts of this system that we can't modulate. We really can't change the pressure of the orbit. We really can't change the CSF, spinal fluid pressure, unless you do a shunt. I mean, you technically could do VP shunts. And we know that people that have hydrocephalus, other neurologic conditions, when they have VP shunts, there are definitely changes on the optic nerve. So there's a whole system here. And that's what John Berdahl's research on, which is goggles that you wear over your eyes at night that apply pressure to the orbit, hopefully making or adjusting the system. How do we adjust this so we prevent axonal injury? So that's good. And there's one more part to that too that I didn't draw on here. I'm really getting into the details. There's perfusion pressure to that optic nerve. And that's why you might hear me talk about some of our elderly patients who are vasculopaths. They've got all this heart disease, they're on pacemakers. They have very poor perfusion to the optic nerve, so they're a lot more susceptible to injury. And they might be on blood pressure medicine at night that their pressure goes too low. Their blood pressure might go to 60 at night, they don't even know. Or they might have sleep apnea and they might stop breathing at night. So in these situations, there's going to be other parts to this that as eye professionals we're not really treating, but it is important for the disease itself. Okay, let me get some more space here. Hold on. So hopefully this is helpful so far. Let's erase this section. Keeping that anatomy up because okay, wait, do we have any more towels? That's it. So another way to classify it besides anatomy is by the cause, and you'll see all these other terms, at least in some of our patients. So let's talk about some of these subcategories. So this is classifying glaucoma based on underlying etiology. It's a little bit different way to think about it. One, which is pretty common in our patient population, is pseudoexfoliation. This is a subtype. Pseudoexfoliation patients are technically, you could call it open angle glaucoma because they have an open angle typically, but they also have pseudoexfoliation. Anyone know what that is? This is one of my favorite ones because there's a lot of nuances to it that if you hear the story, you will never forget it. So, you know, in medicine, when we say pseudo, it usually means fake or false. And you know the other word, exfoliation, because everyone knows an exfoliation. People think about the skin exfoliating. So this is an exfoliation disease of the eye. But why would we call it pseudoexfoliation? So there's a whole history to this. In the past, there was a group of glass blowers in Italy that they were having eye trouble. And when they looked at these glass blowers from Italy, they looked at their eyes, they had all these debris and flakes floating inside their eyes, these proteins, these little flakes. So that is where exfoliation disease came from, which is the glass blowers in Italy. So that's a classic example of true exfoliation disease. That's someone who's a glass blower. What happens is they're looking at the hot red glass is bright red and glowing, and the infrared light being discharged right into their eyes was causing just a sloughing of some of the proteins of the iris, the internal structures of the eye, and this protein would start to fill the eye. And that's true exfoliation. We don't have any glass blowers out here, although I did meet one out here who's an artist in Palm Springs, blows glass, and I looked, they didn't have it. But I guess these are people as a profession who do glass blowing all the time, and they get it. I've actually never seen true exfoliation, so don't quote me on that. So pseudoexfoliation is someone that kind of looks like an exfoliation patient who's a glass blower, but they're not a glass blower. And there's some sort of genetic predisposition to this, where we start to see these white proteins slough off and fill the anterior chamber. It's not a glass blower, but they have this. And interesting associations with this, number one, is they are more likely to have labile IOP. You can imagine if a lot of that protein sloughs off all at once, it's going to clog up the canal there, and you're going to have a pressure spike. Like when it rains here in Coachella Valley and the sewer systems clog, it just fills up. So they'll have a pressure spike. Number two, they have loose zonules. Remember, the zonules are the support systems here that suspend our lens in the eye. So they can have loose zonules. And this is why I really love pseudoexfoliation, because I get to talk a little bit about cataracts with it. Patients with pseudoexfoliation, not only do they have labile IOP, glaucoma issues, they also have a much higher rate of complications with cataract surgery. So we're going to see their zonules loose. We're going to see them even after cataract or during cataract. The whole lens complex can dislocate, sublux. And one more case to talk about, and this is in cases of maybe surgical or trauma to the eye for a patient who had cataract surgery. And if you go online and you look at my video about posterior capsule rupture, you will see if there's a complication and there's a lens implant in here, and we couldn't put the lens in the normal spot. We had to put it in the sulcus. Let's say our lens was placed in the sulcus, or let's say the whole structure has been damaged. We couldn't get it in the sulcus either, and they put it in the anterior chamber. This would be an anterior chamber lens, anterior chamber IOL. You can see that it is right up against the iris. It is literally opposed to it. There's no sulcus, there's no space. Like, like in a natural eye. And so what will happen is you'll have these episodes where the lens kind of rubs on the iris and it creates inflammation. And the inflammation can then cause neovascularization. We start to see blood vessels growing in there because of the inflammation. We can see those blood vessels bleed, so we get a hyphema, we get uveitis, and we get glaucoma. This is the UGG syndrome. This is kind of putting a lot of it together that we talked about. So the uveitis, we're seeing white blood cells float around the anterior chamber that can clog up the drainage flow. The glaucoma is as a result of that, and the hyphema, that's related to that too. The most common cause of UGG syndrome, UJ syndrome, is one of these issues, which means the definitive treatment actually is to somehow move the lens off the iris. And that's where we talk about lens exchange, that's where we talk about doing Yamane, other ways to move the lens off the iris. That usually helps treat this. So in this situation, it's a mechanical effect of just the structure of the iris lens complex. I love that one because you don't want that. That means there's a problem with your cataract operation, or you had cataract and trauma after the fact. And for a lot of the patients we see for second opinions, they've got this. They had a problem with their cataract, and now we're looking at ways to remedy that. Okay. Let's go ahead and...
I think I missed this part, but why would the lens end up in the anterior chamber?
That means there was no capsule support at all, and you couldn't put the lens in the capsule because it would fall out of position. So to kind of get a good drawing and description of that, watch that poster capsule rupture video. It's under the Botched Cataract series on YouTube. It's actually a pretty high rate of capsule rupture. In some of the studies you'll see maybe up to 4%. And I talk to the techs at El Mirador, they see these every week. Every week they have to deal with the capsule rupture. It's all the time. I don't know what their monthly rate is there at El Mirador, but across the country it's about 4%, which means if you're a cataract surgeon and you do about 1,000 of these a year, you're going to have, at least a couple dozen on average that are ruptured. Well, unless you're here, we don't really see that. It's really rare for me to get that. I can count in my career, just rarely does that happen. I had to deal with a lot of them when I was training residents. It was happening all the time. This research just came out looking at complication rates. It's the beginning surgeons, the ones that do low volume. So the surgeon who might do 2 or 6 a week, they don't do that many. Or the surgeons that are fresh out of training, their complication rate is a lot higher than the surgeons doing high volume. So the high volume surgeons are faster, much lower complication rate, and so I think for patients looking for cataract surgeons, that's kind of what you want. You want someone that's doing enough that they're efficient, less likely to have those issues. I wouldn't go to a cataract surgeon that's only doing a couple a week because technically you get that feeling. It's almost like if you're into sports, you can't just go up to the plate and swing and hit a home run. You kind of do a few practices, you warm up. You kind of have to warm up and practice all the time. You can't just go once a month on the plate and expect to be, a superstar. You got to really go every single day. Now you could be a decent baseball player and play intramurals going once a month, but if you're really going to be good, if you're going to be a pro, you got to be at the gym. You got to be on the field. You got to practice all the time. So, same thing with cataract surgeons. You don't want a surgeon that's taken a 2-month sabbatical. You don't want a cataract surgeon that maybe has gone on sabbatical to do research for 6 months. You want a guy who's working every week, that's doing high volume, and that's the guy who's less likely to have an issue. We're going to be, I've been thinking about that because we're working on a video for that. So, watch that video on capsule rupture. You'll see more about that. So some risk factors. You can actually go online and look at this OHTS calculator. There's an OHTS study, and you'll see me pull this up sometimes. It's a really great teaching tool. The ocular hypertension treatment study, they looked at thousands of patients across the US and Europe. What are the risk factors? They did this multivariate analysis, huge study. So we now can plug in patient data into this calculator and tell them what their 5-year risk for getting glaucoma damage will be. It's a really powerful tool. You can say, hey, your risk is only, less than 5%. Don't worry, we'll just track you. Or while your risk is over 30%, we need to get your pressure down. So when you look at the US, I found some numbers, so that's why I have notes. In the US, we're looking at 2.25 million. This is a lot of people, and that's in the 45 and over crowd. That's a huge number. Actually, probably most of them don't even know they have it. And worldwide, some report from the WHO I found was 104.5 have increased eye pressure. They don't even know it. So across the world, this is why glaucoma is one of the leading causes of blindness. There really are no symptoms of it in the early stage. You can't feel if your pressure is 30. There's no sensation. You could feel if it's 80. It hurts. Like our phacomorphic glaucoma patients, they'll go to the ER. Or our neovascular patients are going to be 80. They're going to go to the ER. But your normal primary open-angle glaucoma, there's no symptoms. And it is so easy to miss. You might have a patient with normal pressure, but they have optic nerve damage. They don't even know it. They go to just a health fair to get a pressure check. It's normal, but they're having optic nerve damage. That happens. People say, well, I had it checked at the health fair. Well, they didn't look at your optic nerve. That's important. They didn't look at your anterior chamber. They didn't look for pseudoexfoliation. They didn't do a full assessment. They didn't look at your retina. So often glaucoma can go undiagnosed, and that's the frightening thing about it. In the US, as long as the patient is going to their regular screening with their optometrist, we're pretty good. We're very diligent about screening and picking up early disease and preventing it from getting to the end stage. But worldwide, it is one of the leading causes of blindness. So risk factors, the one that everyone talks about is age. And that's in the calculator. Age is like the number one thing you type in. Let's say you are 40 years old, you're probably not going to have it. Let's say you're 70. Well, there's probably a 3 or 5 time higher risk you have glaucoma at the age of 70 versus 50. And they'll say, well, I had it checked 10 years ago, I was fine. I went to UCLA, they did every test, and they said I'm fine. Well, now that was 10 years ago, or that was 2 years ago. You're older now, your risk is higher. So as you age, your risk goes up. Another risk factor, interestingly, is decreased central corneal thickness. On the flip side, if your cornea is thicker, it's protective. That's why we'll test this central corneal thickness. You do this as a tech, you want to make sure at least once in the patient's lifetime, if we're looking at glaucoma risk assessment, you want CCT. That's actually part of our calculation about their 5-year risk. We want to ask, what is their family history? So when you're doing your workup, hey, it's a new patient. Did anyone in your family have glaucoma? Okay, well, there are genetics, as we talked about earlier about this. Next, a diurnal IOP. Now the IOP does fluctuate throughout the day, and they'll say, well, how come last time it was 14 and now it's 16? Oh no, it's 2 points higher. Well, don't worry, it goes up and down. If we check you this afternoon, it'll be a little different. It's going to go up and down, and that's going to depend on the episcleral venous pressure. It's going to depend on this, how much your body's producing. There's so many factors. It's going to fluctuate throughout the day. We find that people that have large fluctuations are more likely to have glaucoma damage. So the optic nerve can't tolerate a roller coaster pressure. So keep that in mind when you hear the patient tell you, oh yeah, I just skip my dose of brimonidine at night. I forget. Well, they're putting themselves at greater risk. You'd rather have a more constant pressure than an up and down. As the brimonidine wears off, the pressure is going to go up. You have more of a spike. So we want more consistent pressure. Some of our patients, you may notice, I'll have them, well, we look at pressure at 9 o'clock a.m. Well, next time you come, let's do an afternoon appointment. Let's try to get it at a different time of the day, because diurnal IOP fluctuations are a risk. Next, race can actually be a risk. We already talked about the Inuits, higher risk of angle closure. We know that African Americans, much higher rate of glaucoma, and then kind of in maybe a little higher than maybe Caucasians would be Asians, and Hispanic rate a little bit higher than Caucasian for at least your primary open angle glaucoma. Maybe symptoms, really not much to talk about in the early stage, but let's talk a little bit about how we diagnose it with visual functional decline. So that's the visual field test. Because early stage, no symptoms, that's why most people don't even know they had it. So let's say we looked, we saw their pressure was a little high, maybe the cornea was a little thin, they've got a family history, maybe they're in a higher risk race, maybe their eye pressure is a little borderline, and their optic nerve shows some risk too, which we'll go over in a sec. We do a visual field. There are characteristic and progressive visual field findings. The earliest one that's very common is what we call a nasal step. So you'll see the visual field, there's the normal blind spot, and there's a little chunk of the field missing here. So everyone has a physiologic blind spot about 15 degrees off center. This is going to be on the edge. If you do a 24-degree field, this is 24 degrees out there, and yeah, that would be one of the earliest signs of visual field loss in classic glaucoma. This patient that shows a nasal step, I'm probably going to initiate treatment. As the disease gets worse, we're going to find other findings. Now, let me pause there, because if I maybe explain some of the anatomy, you will understand why we get these field losses, and I think that would be helpful to understand this. Okay. Oh, thank you. So as the nerves go from our brain to the optic nerve and connect to the retina, so let's do our diagram looking on the optic nerve and the retina. There's the blood vessels. The most important part, as you know, is the fovea. That's kind of our center fixation. The way the nerves travel through the retina looks like this if we do a diagram. The ones here go straight, the ones here, and they kind of arch. I don't know if you've seen pictures of this, but this is the way they arch. And this is how the nerves kind of fill the space. They all coalesce around that fovea. When we look at optic nerve damage in patients, we look at what's called the cup to disc ratio. Normal cup to disc is less than 0.5. So I'm going to zoom in on the optic nerve. I'm going to look at the outer rim, the inner rim, and this is where the blood vessels kind of come out of. They kind of go over that rim of the optic nerve. So we're looking literally at the ratio, the total vertical height of the nerve, and the inner rim which is right here, and that is our ratio of cup to disc. This would be normal. It's not that bad. It's like a 3. The average might be a 2 or a 3. So when there's axonal injury, when that optic nerve is really having some trouble and it's not resistant to the pressure changes, we're going to see neuronal injury, axonal damage and loss and thinning. So now all of a sudden when we look at the optic nerve, it might look like this. Some of the neurons have been damaged. Now it's thin. We can literally see this thinning effect happen. So now all of a sudden our cup to disc, if we look at the total and then from here to here, now this is looking like a 0.6. This is bad. When you have a cup to disc greater than 5, like in this case 0.6, especially when it's really thin here, now we're probably going to start to see some visual field damage. So all these neurons here are going to cut this whole field here, and when you see a nerve damage like that, we call that field loss and arcuate. An arcuate defect. And well, it's flipped in the eye, so whether I drew this upside down because I'm using a lens or whether I anyway, well, when you do the field test, it may look something like this, where we see an actual defect like this, an arc that connects to the nasal step there. So this is why when we look at our glaucoma patients, we really need to look at the optic nerve. That cup to disc ratio is vital. The visual field progression is vital, because some patients, we may lower the pressure, 5 years later it's not enough, we have to lower it even further because they're still having progression despite being on 1 drop or 2 drops of medication. So I hope that makes sense. If you understand the neurons, the way things flow, how that looks clinically, how that looks on the visual field, we piece all this together. Got that part, okay. It's kind of interesting, it always goes back to the definitions. Now, on our workups, we'll typically do a visual field annually. Unless there's concern, we might do it a little sooner. We are looking at the optic nerve every single visit. We're looking at the eye pressure every single visit. Lecture on here. Okay. So people ask, well, if I do have glaucoma, is it bad? I mean, are you going to treat it? Well, yeah. There's some categories. You've got the first one, which is medication. I think Frances is the pharmacologist here. She can tell you a little more than I can about that. But we'll go over it. There is laser. There's surgery. So I'm going to start with medication because this is probably the primary way we treat it. Name one common medication you see people on right now.
Latanoprost.
Okay. So latanoprost. If you kind of learn some of the medications and their families, some of the side effects, when people call as a liaison, it's good to know some of these things. Or as a tech, it's good to know some of these things as you prescribe them. Latanoprost, the other one would be brometoprost. It goes by brand names like Travatan. Okay. So people ask, well, if I do have glaucoma, is it bad? I mean, are you going to treat it? Well, yeah. There's some categories. You've got the first one, which is medication. I think Frances is the pharmacologist here. She can tell you a little more than I can about that. But we'll go over it. There is laser. There's surgery. So we're going to start with medication because this is probably the primary way we treat it. Name one common medication you see people on right now.
Latanoprost.
Okay. So latanoprost. If you kind of learn some of the medications and their families, some of the side effects, when people call as a liaison, it's good to know some of these things. Or as a tech, it's good to know some of these things as you prescribe them. Latanoprost, the other one would be brometoprost. It goes by brand names like Travatan. Okay, in this part of the video, this is when our camera ran out of battery, so we lost a couple minutes of the lecture, but we're going to go ahead and fast forward to the next section, and it is right here. So they work. The way the prostaglandins work is they target the trabecular meshwork, they cause a remodeling, and then when those trabecular meshwork cells are remodeled, now we're going to have increased outflow. So it's working on the outflow part of this aqueous circulation. Usually these are prescribed once a day at night. So that's why it's the go-to. It's super easy to use. Just put one drop in at night, you're done. I always go over some of the side effects with every patient before we begin this medication. Number one is increased eyelashes. Most people, at least half of them, welcome this side effect. It makes sometimes up to 30% longer, fuller eyelashes. In fact, it became known pretty quickly that this was a side effect, and 20 years ago or so, that's when they started to market these prostaglandins as Latisse. So our glaucoma patients get their insurance to pay for Latisse for free for them sometimes. So increased eyelash growth, great. Number two, it can make the eyes a little red for the first couple weeks. Number three, if you have hazel or green eyes, it can deepen the pigment. It can darken the pigment, and that's permanent. So darkening or deepening of a pigment of the iris color. So your green eye will look brown. Your light brown will be a dark brown. I don't see that effect on our brown-eyed patients or the blue-eyed patients. Just the hazel, that's where you have to warn them about that. So there's that, and that can be permanent. So we have a patient with the bluest eyes ever, and she is so fearful of losing her blue eyes, so she refuses to use this, even though probably not going to happen for a blue-eyed patient. It's usually green. So next category, what's another common eye drop you see? Timolol. Oh, awesome. Do you know what category that is? I'll tell you, it's a beta blocker. This is your timolol. This is your betamol. This is your istalol. Probably the only two you really see are timolol and betamol. Do you know how these are prescribed?
Is it paired with dorsalizing?
Yeah, you can. Well, that's another category. Hangs on to that.
Once a day morning.
Yeah, you can do twice a day, or you can actually do once a day, because we're going back to that diagonal curve. There often is a little increase in eye pressure in the morning. So sometimes they'll prescribe the timolol just in the morning. This is one drop in the morning. Sometimes I'll prescribe it twice a day. Because it is a beta blocker, it works by, it's going to inhibit what is called C-amp, which is these, well, you remember that from the biology history? I have to write this down, cyclic adenosine monophosphate. And this is going to be right at the epithelial cells of the ciliary body, and it's going to then decrease production of aqueous. So this is working by decreasing production. We're modulating this part of the body. Now, major side effects, beta blockers. As you know, it has systemic effects. So we're going to be worried about our patients with asthma because it is really bad for asthmatics. It's going to even induce asthma attack. It's really bad for our patients with low heart rate or low blood pressure because it does that. So if they already have bradycardia, this is a bad medicine. We can't use it. So before you start someone on Timolol, you often need to ask, hey, do you have asthma? You'll see me checking their medical record. Hey, I want to make sure they don't have asthma. I'll make sure they don't have COPD, lung disease. I'll make sure they don't have heart disease because that's not a good situation. And finally, one thing some may notice is fatigue. Oh no, they're tired. You already have someone who's in their 70s, they're napping all day long, and you give them a beta blocker, they're even worse. These scenarios I warn the Timolol patients about before we start them on it. Sometimes they'll be on Timolol for 10 years, they get admitted to the ICU in the hospital because they have a heart attack. Well, we got to stop the beta blocker because we don't want them to go hypotensive. We don't want their blood pressure to drop after they get discharged. So we always work with their cardiologists in these scenarios. The beta blocker, the Timolol patient, you should, and actually in some practices they will ask routinely, what is your blood pressure? What is your heart rate? Let's check it. And if they're on beta blockers, something to ask, how's your heart? You'll see me in the room, hey, have you seen your cardiologist? What are they telling you? This is the questions I have for the beta blocker patient.
Is it because of all these reasons, is it better to give botanopros or?
Oh yeah, that's why we go to this one. I mean, the side effect profile of this is like minimal. It's, oh, your eyelashes got longer. Okay, not that bad. But this one, oh my goodness, you can't breathe anymore. That's bad.
They target basically the same thing, or is it
no, they don't.
they're prescribed for a narrow angle and the other one for open angle?
Remember, narrow angle, if you do the iridotomy, you're done.
Mm-hmm.
These are all for open angle or mixed mechanism. The narrow, once you do the laser, that's it. You're not doing anything. So these are going to be more long-term chronic open or mixed. They work completely different. This is going to work on the trabecular meshwork. This is working on the ciliary body. Let's put that here, TM and Schlemm's canal. So different parts that we're working on. We'll go to the dorsolamides. We also have acetazolamide, all of them amides. That'll be how they end. That is this category called carbonic anhydrase inhibitors, CAIs. As the category sounds, they inhibit carbonic anhydrase, which is going to also, just like Timolol, decrease production. So we're going to have decreased production of aqueous, and that's going to lower pressure. These are usually prescribed as 2 or 3 times a day dosing. So dorzolamide, 2 or 3 times a day dosing. Interesting, because the dorzolamide and Timolol, they're older, they've been around a long time. You'll often see them, like you mentioned earlier, they're often combined. Because they're twice a day, they're on the same dose schedule. So why not? So let's say we only got 10% reduction of pressure on the Timolol. We need a little more, so you do a combo. Now the patient's still only doing twice a day. Compliance is a little better that way, versus having 2 or 3 meds, just one bottle of combo. So the main thing I tell people on this one is, number 1, are you allergic to sulfa? If you are, this is bad. Do not use it in sulfa patients. Occasionally, I've met a few people over the years. Their eye doctor somewhere else gave them dorzolamide, even though they had a sulfa allergy, and they're okay. I don't know if that was a misdiagnosis of allergy to sulfa, or not everyone has a cross-reactivity, but if I ever see sulfa allergy, I don't do dorzolamide. Next thing to know about these is they really burn, so you always warn them, oh yeah, it's gonna burn for 20 seconds. That's normal. If you tell them that as you send it to the pharmacy, you're not gonna get a phone call the next day. Oh my goodness, it burns, is that normal? Yeah, that's normal. Just close your eyes, let it soak in for a minute or 2, you're fine. Another category, Another medicine you see.
This one's quite messy.
I'll do one for you. Brimonidine.
Mm.
I love this one. It is also known as Alphagan because it is an alpha adrenergic. We love this one. It really helps for in the perioperative period after a laser, whether it's a YAG or an iridotomy. It works pretty quickly. It's been shown in some animal studies to have a neuroprotective effect somehow. We don't quite know how. The way alpha adrenergic agonists work is they're going to prevent the release, they're going to reduce or block the release of norepinephrine at the nerve terminals, which I don't think it's fully understood how this happens, but it lowers pressure because of that. The main thing to think about that I tell people with alpha adrenergics is it's a higher chance of allergic conjunctivitis. It may not even be right away. It may be 5-10 years later. And it may be up to 15% of people can develop an allergy to this. This alpha adrenergic effect also causes vasoconstriction, which some people like because now their eyes aren't as red. In fact, you can use a low dose alpha adrenergic agonist and you can buy it over the counter now as Lumify. So it's got the same medicine in it that we use at a higher dose for glaucoma. I'll sometimes use the brimonidine before surgery because it causes vasoconstriction. We're less likely to have bleeding on the conjunctival vessels. So a very great category that I love. I just warn people about the allergy effect on this because over the years we've had several people that you eventually have to stop. They'll develop a conjunctivitis and the eyelids get all itchy with the dermatitis, and there you have it. Next, this is kind of a newer category. This is the Rho kinase inhibitors. This is like your Rhopressa. They also work by modulating the outflow. This is very nice because it's once a day dosing. Oh, by the way, this is like 2 or 3 time a day dosing. This is 2 or 3 time a day dosing. This is 1 or 2 time a day dosing. This is 1 time a day dosing. So the Rho kinase, 1 time a day dosing, usually at night. It can come in combo. They make a combo with a prostaglandin analog. This is a newest one. We have the hardest time getting insurance coverage for it still. And then finally, maybe just so that you're aware, an older medicine, pilocarpine. Rarely do we use this for long-term glaucoma. Pilocarpine is a constrictor. It constricts the pupil, so we'll use it before an iridotomy. Makes the pupil small, meiosis. It also causes the whole ciliary body to rotate and contract. And the thought is that by contracting, we're now opening up the scleral spur, allowing, by that improved opening, better outflow. Because of that, pilocarpine contracts this area. It's also been associated with retinal tears. Because if it contracts, we're going to tear right next to that structure and the eye will detach. So it's kind of an older medicine. This is usually, I've seen it prescribed 2 to 4 times a day. And it makes the pupil really small, and a lot of people can develop headaches with it. You can get retinal detachments. If you're on it long term, you can get cysts inside the eye. So we rarely do prescribe this long term. It's like a really old medicine. But we use it temporarily for meiosis. Pretty good for that. That's what I call it. So prostaglandins, so they work. The way the prostaglandins work is they target the trabecular meshwork, they cause a remodeling, and then when those trabecular meshwork cells remodel, now we're gonna have increased outflow. So it's working on the outflow part of this aqueous circulation. Usually these are prescribed once a day at night. So that's why it's the go-to. It's super easy to use. Just put one drop in at night, you're done. I always go over some of the side effects with every patient before we begin this medication. Number one is increased eyelashes. Most people, at least half of them, welcome this side effect. It makes sometimes up to 30% longer, fuller eyelashes. In fact, it became known pretty quickly that this was a side effect, and 20 years ago or so, that's when they started to market these prostaglandins as Latisse. So our glaucoma patients get their insurance to pay for Latisse for free for them sometimes. So increased eyelash growth, great. Number two, it can make the eyes a little red for the first couple weeks. Number three, if you have hazel or green eyes, it can deepen the pigment. It can darken the pigment, and that's permanent. So darkening or deepening of a pigment of the iris color. So your green eye will look brown. Your light brown will be a dark brown. I don't see that effect on our brown-eyed patients or the blue-eyed patients. Just the hazel, that's where you have to warn them about that. So there's that, and that can be permanent. So we have a patient with the bluest eyes ever, and she is so fearful of losing her blue eyes, so she refuses to use this, even though probably not gonna happen for a blue-eyed patient. It's usually green. So next category, what's another common eye drop you see? Timolol. Oh, awesome. Do you know what category that is? I'll tell you, it's a beta blocker. This is your timolol. This is your betamol. This is your istalol. Probably the only two you really see are timolol and betamol. Do you know how these are prescribed?
Is it paired with dorsalizing?
Yeah, you can. Well, that's another category. Hang on to that.
Once Sunday morning.
Yeah, you can do twice a day, or you can actually do once a day, because we're going back to that diagonal curve. There often is a little increase in eye pressure in the morning. So sometimes they'll prescribe the timolol just in the morning. This is one drop in the morning. Sometimes they'll prescribe it twice a day. Because it is a beta blocker, it works by, it's going to inhibit what is called C-amp, which is these, well, do you remember that from the biology history? I have to write this down, cyclic adenosine monophosphate. And this is going to be right at the epithelial cells of the ciliary body, and it's going to then decrease production of aqueous. So this is working by decreasing production. We're modulating this part of the body. Now, major side effects, beta blockers. As you know, it has systemic effects. So we're going to be worried about our patients with asthma, because it is really bad for asthmatics. It's going to even induce asthma attack. It's really bad for our patients with low heart rate or low blood pressure, because it does that. So if they already have bradycardia, this is a bad medicine. We can't use it. So before you start someone on timolol, you often need to ask, hey, do you have asthma? You'll see me checking their medical record. Hey, I want to make sure they don't have asthma. I'll make sure they don't have COPD, lung disease. I'll make sure they don't have heart disease, because that's not a good situation. And finally, one thing some may notice is fatigue. Oh no, they're tired. You already have someone who's in their 70s, they're napping all day long, and you give them a beta blocker, they're even worse. So These scenarios I warn the timolol patients about before we start them on it. Sometimes they'll be on timolol for 10 years, they get admitted to the ICU in the hospital because they have a heart attack. Well, we got to stop the beta blocker because we don't want them to go hypotensive. We don't want their blood pressure to drop after they get discharged. So we always work with their cardiologists in these scenarios. The beta blocker, the timolol patient, you should, and actually in some practices they will ask routinely, what is your blood pressure? What is your heart rate? Let's check it. And if they're on beta blockers, something to ask, how's your heart? You'll see me in the room, hey, have you seen your cardiologist? What are they telling you? This is the questions I have for the beta blocker patient.
Is it because of all these reasons, is it better to get botanopros or?
Oh yeah, that's why we go with this one. I mean, the side effect profile of this is like minimal. Oh, your eyelashes got longer. Okay, not that bad. But this one, oh my goodness, you can't breathe anymore. That's bad.
They target basically the same thing, or is it
no, they don't.
they're prescribed for a narrow angle and the other one for open angle?
Remember, narrow angle, if you do the iridotomy, you're done.
Mm-hmm.
These are all for open angle or mixed mechanism. The narrow, once you do the laser, that's it. You're not doing anything. So these are going to be more long-term chronic open or mixed. They work completely different. This is going to work on the trabecular meshwork. This is working on the ciliary body. Let's put that here, TM and Schlemm's canal. So you know, different parts that we're working on. We'll go to the dorsolamides. We also have acetazolamide, all of them amides. That'll be how they end. That is this category called carbonic anhydrase inhibitors, CAIs. As the category sounds, they inhibit carbonic anhydrase, which is going to also, just like timolol, decrease production. So we're going to have decreased production of aqueous, and that's going to lower pressure. These are usually prescribed as 2 or 3 times a day dosing. So dorzolamide, 2 or 3 times a day dosing. Interesting, because the dorzolamide and timolol, they're older, they've been around a long time. You'll often see them, like you mentioned earlier, they're often combined. Because they're twice a day, they're on the same dose schedule. So why not? So let's say we only got 10% reduction of pressure on the timolol. We need a little more, so you do a combo. Now the patient's still only doing twice a day. Compliance is a little better that way, versus having 2 or 3 meds, just one bottle of a combo. So the main thing I tell people on this one is, number 1, are you allergic to sulfa? If you are, this is bad. Do not use it in sulfa patients. Occasionally, I've met a few people over the years. Their eye doctor somewhere else gave them dorzolamide, even though they had a sulfa allergy, and they're okay. I don't know if that was a misdiagnosis of allergy to sulfa, or not everyone has a cross-reactivity, but if I ever see sulfa allergy, I don't do dorzolamide. Next thing to know about these is they really burn, so you always warn them, oh yeah, it's gonna burn for 20 seconds. That's normal. If you tell them that as you send it to the pharmacy, you're not gonna get a phone call the next day. Oh my goodness, it burns, is that normal? Yeah, that's normal. Just close your eyes, let it soak in for a minute or 2, you're fine. Another category. Another medicine you see. I'll do one for you. Brimonidine. I love this one. It is also known as Alphagan because it is an alpha adrenergic. We love this one. It really helps for in the perioperative period after a laser, whether it's a YAG or an iridotomy. It works pretty quickly. It's been shown in some animal studies to have a neuroprotective effect somehow. We don't quite know how. The way alpha adrenergic agonists work is they're going to prevent the release, they're going to reduce or block the release of norepinephrine at the nerve terminals, which I don't think it's fully understood how this happens, but it lowers pressure because of that. The main thing to think about that I tell people with alpha adrenergics is it's a higher chance of allergic conjunctivitis. It may not even be right away. It may be 5-10 years later. And it may be up to 15% of people can develop an allergy to this. This alpha adrenergic effect also causes vasoconstriction, which some people like because now their eyes aren't as red. In fact, you can use a low dose alpha adrenergic agonist and you can buy it over the counter now as Lumify. So it's got the same medicine in it that we use at a higher dose for glaucoma. I'll sometimes use the brimonidine before surgery because it causes vasoconstriction. We're less likely to have bleeding on the conjunctival vessels. So a very great category that I love. I just warn people about the allergy effect on this because over the years we've had several people that you eventually have to stop. They'll develop a conjunctivitis and the eyelids get all itchy with the dermatitis, and there you have it. Next, this is kind of a newer category. This is the Rho kinase inhibitors. This is like your Rhopressa. They also work by modulating the outflow. This is very nice because it's once a day dosing. Oh, by the way, this is like 2 or 3 time a day dosing. This is 2 or 3 time a day dosing. This is 1 or 2 time a day dosing. This is 1 time a day dosing. So the Rho kinase, 1 time a day dosing, usually at night. It can come in combo. They make a combo with the prostaglandin analog. This is a newest one. We have the hardest time getting insurance coverage for it still. And then finally, maybe just so that you're aware, an older medicine, pilocarpine. Rarely do we use this for long-term glaucoma. Pilocarpine is a constrictor. It constricts the pupil, so we'll use it before iridotomy. Makes the pupil small, meiosis. It also causes the whole ciliary body to rotate and contract. And the thought is that by contracting, we're now opening up the scleral spur, allowing, by that improved opening, better outflow. Because of that, pilocarpine contracts this area. It's also been associated with retinal tears, because if it contracts, we're going to tear right next to that structure and the eye will detach. So it's kind of an older medicine. This is usually, I've seen it prescribed 2 to 4 times a day, and it makes the pupil really small, and a lot of people can develop headaches with it. You can get retinal detachments. If you're on it long term, you can get cysts inside the eye. So we rarely do prescribe this long term. It's like a really old medicine. But we use it temporarily for meiosis. Pretty good for that. Okay. So, checked off medication. So for laser, laser is always going to modulate some part of the anatomy or tissue. We've already talked about iridotomy, so we're going to skip that part. We're going to talk about the 2 parts of the eye here that we can modulate with the laser. 1, the trabecular meshwork, and 2 is the ciliary body. So let's start with the trabecular meshwork. So if we're going to treat the trabecular meshwork, That is called a trabeculoplasty. We are going to aim a laser onto the trabecular meshwork to modulate the tissue so there's better outflow. 2 lasers can be done for that, SLT or ALT. They work on the exact same anatomy of the eye. One is a YAG laser with a Q switch, one is an argon laser. Of the 2, my preference is SLT, less chance of scarring, very benign laser to go through. You should know for SLT laser patients, I usually will see a full effect a month or 2 later. The effects can last 2 to 5 years and it sometimes wears off. You can actually repeat these, but it's a less effective second time around. So if we have a patient who can't tolerate the eye drops, too many side effects, they've got asthma, their eyes are red, or they forget to use the eye drops, they just can't remember, their life is too busy, then we'll do this treatment to buy them some time. The other way to treat is the ciliary body. You notice it's really deep inside there. So how do we get to the ciliary body with a laser? Well, either A, you can get it externally. You kind of have to really hit it with a very potent laser to get through the conjunctiva, to get through the sclera, to get in there, to zap it. These are just doing a plasty or a tickling of the tissue to remodel the cells. If we're targeting the ciliary body, we want to turn down the valve, shut down the valve that's creating the aqueous. So these are destructive procedures. We want to kill the ciliary body slightly, zap it to kill it so that it's producing less aqueous. We literally want to destroy some of the ciliary epithelial cells there, so we're not making as much aqueous. These are categorized, I would call it under this category called ciliary body destructive procedures, or CPC is what we do. Cyclophotocoagulation. We take a laser from the outside of the eye, turn up the power really high, zap through the entire conjunctiva, through the sclera, right to the pigment of the ciliary body, and that kills it. Turns the switch off, that makes the aqueous. You can also surgically go inside the eye, kind of snake around the iris, and directly visualize it with the endoscope. So that would be endoscopic. But you need to be in surgery. You actually have to make an incision, scope and endoscope in there and zap it. So of the 2, cyclo is less cutting. Because this is a destructive procedure, I typically, and I think a lot of people do this too, typically use this as a last resort procedure, because historically 20 years ago, when we weren't as refined with the technology, you would do the CPC laser and it would kill off the ciliary body so bad that the pressure would tank and go to 0 and they lose the eye. So nowadays with like our new G6 lasers, it's a lot more gentle, and we'll often undertreat just so not to overdo it, not to overpower the eye. These are the lasers. Questions on those?
Can you do CPC multiple times too?
Yeah, you can keep going in. So, yeah, let's say, hey, I have a patient, they're on all the meds, they're 30, I do laser, we get them down to 22. Well, I want to go a little more, you just go back in, you keep zapping. So, interesting thing with CPC, we don't actually visualize where we're lasering, we're just kind of guessing. We're, maybe 2 to 3 millimeters behind the limbus. We're guessing where that is. So what if it's like a little bit this way? What if it's, what if our hand is where their eye moves? So we're almost guesstimating where that is. We're not directly visualizing it. So there's some unpredictability of it. And also everyone has a little bit of pigmentary changes, variation. And so the laser energy is absorbed by melanin. So if they have more melanin, they're going to have a more robust response versus someone with lighter pigment. Same goes with the TM too. It's the pigment that absorbs the light energy. The darker the pigment, the more the response. So going back to this one, if you have someone with light blue eyes, they're very fair skinned, they may not have as much of a response as someone who's a pigment dispersion or maybe darker pigment type glaucoma patient. They're gonna have more pigment, they're gonna have a more profound response to the laser intervention. Okay, I will do surgery and then I'll close it off. Okay, final part, surgery, and then I'll finish it off. So, surgery for treatment. Let's maybe do a little history. Maybe that's a good way to understand, because historically, if you go back over 100 years, people with horrible, painful glaucoma, they didn't have any medication, so they tried to make cuts in the eye to drain the pressure. And there's this old case from the early 1900s where they made an incision here, or a paracentesis, and then to prevent it from sealing up, they wanted to keep draining, they put a little horsehair in there. And so they did a horsehair paracentesis, they put a horsehair and the pressure drained. It helped pretty immediately with their high pressure and pain, but then they got an infection, and of course that's not good. So if you go back 100 years, we really were limited. And it wasn't until later that we came up with this surgery called the trab. So the way this works is we look at the structure of the eye, we create a pocket in the conjunctiva, we create a little flap in the sclera, and then we puncture a hole into the eye. So you'll see an iridotomy, surgically made, not by laser, but surgically. And then you kind of gently stitch it all up. So now you have a potential space underneath the conjunctiva that directly communicates to here, with the hope that the pressure will go around, go here, or go up through there, and then fill this bleb. This is called a bleb. So the key to success is you have a bleb that's capturing all the aqueous that's being produced, and then it's kind of filtering back through the venous system, through the lymphatics, back into the body. So we're trying to create a controlled puncture in the eye, hoping it doesn't do too much, hoping it does enough to keep the pressure in a good range. So there's a true art to these trabs, and high complication rate. It can easily get infected even years later. That's called a blebitis. And it wasn't until maybe the 80s and 90s that people looked at other ways to do this. And that's when we look at the tubes. Original doctors, Molteno. You look at the other doctors, Beervelt. And then the one I really like, which is the Ahmed. This happened a little later. But the tubes, the idea behind these is we don't just create a pocket in the conjunctiva, we create a physical mechanical filter there. And you implant a filter, which might be made out of silicone, and it has a tube, and the tube you place inside the eye. You cover that up under this pocket of conjunctiva, and now instead of having the bleb, just a potential pocket, we have a physical mechanical valve or tube that is draining the pressure. So Ahmed is so awesome. He is an amazing, amazing doctor. If you listen to his story, he tells you he was working in Africa, and he was tired of these patients just going blind, and there's nothing you can do because they don't have access. Even if they know they have glaucoma, they can't get the medicine. So he was trying to find a way to do something for them that doesn't require a lot of maintenance. Like if you do a trab, there's a lot of maintenance. You got to keep looking at it. You have to have multiple doctor visits. He wanted more of a hands-free surgery that can take care of the pressure and have a low complication rate, and not to have so many doctor visits, because you're middle of Africa, what are you going to do? You can't see a doctor. So that's how he engineered the Ophthalmic valve. It has a backflow mechanism engineered into it. So typically, like when we do Ophthalmic valves, the pressure is going to be around 8 to 12, as long as things don't clog up. So it's a pretty big surgery. You have this huge piece of hardware. It's probably about the size of your thumbnail, and it's sandwiched between the superior and lateral rectus muscles. And the eyelid covers the whole thing. You don't really see it, but it is a pretty big surgery. And up until maybe 15 years ago, this was our choice. When you failed on the eye drops, you had to jump off the cliff into this major operation, lots of stitches, huge recovery, and there's no middle ground. There's no middle ground for the people that failed the laser, failed the medication, up until recently. So recently, a lot of work has been done to this little section, the angle of the eye. So over the past 10 years, there's been a huge shift in glaucoma, like you could never imagine. Like when I was in training, a lot of these things were just barely being talked about. And all these surgeries now, because it's a tiny space, it's tiny surgery, we call it minimally invasive glaucoma surgery. That's what that stands for. Every single one of these procedures is trying to get better outflow. So surgical operations, outflow. We want more outflow. The only way to change inflow is to kill the ciliary body. So we want better outflow, that's what MIGs do. You can, like one that we do, you can try to place a little catheter and stent Schlemm's canal. That's called an ad internal canaloplasty. Historically, they've tried things like place a little tiny suture in there, string it all the way through the canal to break any adhesions or loculations in the canal, just like doing a rotor-rooter in your plumbing system. We now use, the system that we use is the Omni system. We cannulate it, and then after we cannulate it, we retract that, and we balloon up the whole canal with viscoelastic, which is kind of like a jello-like material that dissolves. So that's one. No implant needed. We're just rotor-rootering the canal system. Next are these little mini stents. The idea behind this is, well, just like in patients that have heart attacks, there's a faulty carotid, blood vessel in the heart. Can we put a little stent to keep that blood vessel open? So the same thing, can we put a stent inside Schlemm's canal to keep it open? So some of the first ones that came out were like the eye stent. Glaukos, the company that came out with this, did tons of research, and it turned out it worked really well. And from there spawned all these other companies that wanted to get into this marketplace, because for a lot of people, we don't want a major operation, one with a lot of complications, one that's just a big surgery. We want these minimally invasive, fast recovery, you're back to work, less downtime, patients are happier, less complications is the main thing. So then all these other procedures came out, like the goniotomies, the co-hook dual blades, which we were doing for a while. Now, like we have Hydrus, you've got the Zen. These are all these little mini stents that are super fast, super efficient surgeries. You don't even have to use stitches. So this is this whole new category of MIG. So now, when we fail medication, when we fail laser, we don't have to go here. We go here first, and then we go to these bigger surgeries. So this is the new order of treatment for glaucoma. It is completely changed in a short period of time. In fact, it changes so quickly, the insurance companies can't keep up with the billing. They keep changing the coding. For Rebecca, they keep changing. I can't keep track of it. There's so many advances, and then the insurance companies catch up. So this is an ongoing, evolving topic. Finishes on treatment. If there's other questions, I don't want to go into too much detail because we're almost 12 o'clock, but final questions on that.
So I get the progression of like medication to laser to surgery. Is there a hierarchy or progression of medications, or is it just personal?
Well, we do the easiest to use and then the least side effect. So most people do prostaglandin, then alpha or timolol, dorzolamide, and then rho kinase would be at the end. Easiest to use, the go-to is always prostaglandin for most people because once a day dosing. Hope that helped.
Thank you.
I don't think I'll get the whole thing on video because our camera died out. So I have to figure out how to next time work around that. But we got
Awesome. Thank you.
it. If you think of new topics as we go along, I didn't talk too much about pressure techniques. We can definitely go over that. I kind of skipped that because we also have liaisons here too. Went to more just general overviews. But if you think of topics that you'd like to cover, we can go over anything. And probably for a while, every couple weeks we'll do this. So, there we go. Okay, that concludes the lecture with our team at Desert Vision Center. I've been doing lectures here and there throughout the past few years, but finally I thought to record it, upload it to the website just so that people who want to access it kind of want to learn more of the specifics, the technicals of some of these diseases. On our next lecture, I'll put it up here. If you have any comments or topics you'd like to talk about, we'll add it on our queue of topics. And until the next lecture, I'll see you on the next one of our playlist.